So what we're going to do is we're going to actually proceed with a presentation from our panel about the existing research landscape. We have one other talk, and then we're going to bring the speakers and the panelists back up to the stage for some time for questions and interactions. And so it's my pleasure to invite C.J. Peters from the Center for Biodefense and Emerging Infectious Diseases at the University of Texas Medical Branch to come forward to talk about existing research landscape on Ebola, past and ongoing initiatives.
Thank you very much. Unfortunately, our information technology people seem to feel like part of their mission statement is to be sure that nobody on the faculty can use the internet. So I don't have any slides, but let me tell you what I'm going to tell you, what I wanted to tell you anyway. I think our mission is to tell basically the truth, the whole truth, and nothing but the truth. And the truth has to include, I don't know. If you don't work in that context, you'll find that some of your truth will be found to be wanting, and your credibility will go down the tubes. The first truth, I think, is the incubation period. The incubation period is advertised as 21.0 days, but as many of you who've worked in this area before will know, incubation periods are a distribution, and usually it's a log normal distribution. And if you look on the internet for Ebola incubation period, you'll find a number of papers using not only the log normal, but the gamma function and so on. And you'll find that the institution period varies according to who calculates it by what formula. So 21 days is basically the longest interval that was found between cases in the 1976 Yambuku outbreak. So it's almost a sure bet, given the way the other calculations work out, that we'll have someone who surpasses that incubation period. I would guess from looking at the calculations, I would guess that there's about a 5% of the people will be found to exceed that incubation period. What that's going to do for the media and the population, I don't know, but it's going to be come back to what Dr. Leduc described as the communication strategy, and somebody's going to have to be thinking about that. Another thing that I think we need to be thinking about is very soon there's going to be a need to compare therapeutic modalities, and that will include drugs, convalescent plasma, cocktails of monoclones. And then it's going to go into something that no one has really talked about in general terms, and that is patient care. If you look at an Ebola patient post-mortem, they're full of antigen. And generally, the fatal cases don't have much of an immune response. So you are left with a difficult situation. And my thoughts would have been that management of fluid and electrolytes would probably not make a great deal of difference. But if you look at the cases that we have in this country, it apparently has. We've had very low case fatality rate here compared to West Africa. And so I think that should be formally looked at. Another thing that's on the menu for treatment modalities is the question of disseminated intravascular coagulation. Evidence for this is present in every patient that's been tested in all the monkey models. So I think we can figure that that's one of the problems How important it is, we don't know, but Tom Geisbert and Peter Darling did some studies with a drug that's actually been in people. It didn't work for thromboembolism, so it's not used widely now, but in the monkeys, it was very efficacious in preventing intravascular coagulation and improved survival and mean time to death for the monkeys that didn't survive. The nematode accessory protein, known familiarly as NAPSI, and that study had a very interesting outcome. The viremias were lower than they were in the control monkeys, consistently and significantly lower. How DIC plays in with virus production is not clear to me, but perhaps it destroys sites of replication. It may act in the spleen to allow more effective immune response, preventing clotting in the spleen. But for whatever reason, that's something that really recommends itself for a disease for which we really have no established therapy. Speaking of established therapy, I'm worried about two things. One is enthusiasm for potentially worthless products that have been given to somebody who's going to survive anyway, and that may well be convalescent plasma, because there's no experimental system where that really works. You don't see suppression of viremia and monkeys getting up off the cage floor and walking. It's just hasn't worked that well. The only report where it seemed to work was a report JID in '99 for some work that was done in Kikwit when we were there. And one of the things that was most striking about that was that there were no controls, and B, when you looked at the deaths that occurred in the rest of the cohort of patients, you saw that these people were destined to survive anyway. They were in a high survival group, that is, young women. They were late in the epidemic, where deaths were somewhat less, and they received their convalescent blood at a time when most patients had already declared whether they were going to live or die. So it was sort of like dessert after you finish the meal. They got a unit of convalescent blood, and that's given rise to a lot of thoughts that I think could lead to a lot of wasted effort and wasted patient time. I believe that we could be better served by testing some of the things that I just mentioned. But if we do use convalescent plasma, then it should be subjected to a rigorous test like anything else. One of the, I'm thinking back to the hantavirus pulmonary syndrome, which was here in the U.S., where things are actually a little easier. But in a situation like this, people don't want to do a controlled trial. They don't realize that without a controlled trial, you'll never be able to bring the full force of what you've been working with to bear on the disease. You won't be able to get the money, you won't be able to get general acceptance and so on when people look back at it. So I think it's very important that we support the drugs and therapeutic procedures that we propose by a controlled double-blind trial, a controlled randomized trial. There are certain other obstacles to this, and that is that this is not a common practice in Africa, and the general attitude that they have, that you find when you go to a Ministry of Health in say Kenya, Sierra Leone, the response is, well, if it works, let's give it to everybody, and if it doesn't work, let's don't give it to anybody. And I think that's a good philosophy, but you don't know whether it works until you've done the trial. So I think we have to resist the impulse and the pressures to just pull something out of the freezer and use it. I guess one of the things that was on my list, which unfortunately didn't make, the electrons didn't make it across the wires, was the issue of staffing. I mean, who's going to do all this stuff? Well, I don't think you want to pull volunteer X into a trial like this. I think we've got terrible problems with staffing, and Dan and Tom and others will talk about that later, but we ought to be able to recruit staffing and be able to release the people who are involved in patient care and so on, who are capable of doing these kinds of trials. Also reminds me that one of the things that we absolutely must fix is we have to do the clinical virology of Ebola. In other words, we have to understand viremias day by day, antibody production day by day, as well as excretion of the virus to the outside. I don't know if any of you have seen anything in the literature about the titer of virus and vomit. I'd very much like to know, but if you look through the literature, vomit is often described as one of the ways to get infected. So I think we need that kind of clinical virology, and for that we've got to fix the export of samples system. You can do RT-PCR on the site, but that is not the same as infectivity. Another related issue is quarantine, because if you knew what was on the outside of somebody, you might know whether or not you should think about quarantine and how effective you would think it would be and how soon it should be. Well, many years ago, I went to Bolivia to work up an outbreak of Bolivian hemorrhagic fever with interpersonal transmission. And I can tell you several things that have rung a bell with me recently. One is I was living in Panama, and my wife worked in the clinical lab. And everybody in the clinical lab said, "Oh, we're so sorry to see C.J. Peters go. We liked him. He's not coming back." And I think that's one of the messages that we don't want to send. And I think there have been some attempts at this. After the outbreak, I was communicating with my boss by ham radio. There was no internet at that time, and no telephone lines to Cochabamba. So I noticed that when I was talking about coming back, that he was strangely silent. So I finally found an airplane that would break the strike, which had come to pass while I was there, and I flew back to La Paz, and there got on the military net and discovered that I wasn't wanted. Panama didn't want me, the U.S. didn't want me, the Canal Zone didn't want me. So I just didn't know whether to do a backstroke out to sea or what to do. Well, Carl, who's a very, very persuasive guy, persuaded them to let me come back if I would undergo a 3-week quarantine. Does this sound familiar? The laboratory had some rooms in the top floor, so I was to, when I came back, I was ushered out of the airport, fastest clearing customs I've ever had in Panama, and ensconced in the attic at our lab. And I can tell you, it's not pleasant after you've had a tense situation and you're coming back and your wife and kids are kind of brought by in the hall and you wave at them. Was not good. But I think we should think about that when we look at these guys who are returning, and if they have a significant exposure, like a needle stick, then I think, they have to go for the quarantine. But these people who don't have highly dangerous exposures don't deserve to be locked up, given what we know or think we know about Ebola. Inevitably, there'll be some assumption that we've made that will turn out not to be true, but right now the dogma is you're not infectious until you're sick, and the sicker you get, the more infectious you get. As far as I can tell, that's based on three things. One is faith. Two is the old Fenner diagram, which has been partly verified for Ebola in monkeys, that the initial growth is in the lymph node draining the site of entry, and subsequently there is viremia, and subsequently this viremia reaches target organs, and presumably this is the point where people become infectious. I don't think this is proven, and it also raises the question is, where is the epidemiological evidence to back this up? And the only thing I've been able to find is a study that Scott Dowell and Tom Kizak and several of us did in Kikwit on families and looking at transmission to family groups of index patients, and that showed that there was very little transmission, if any, at in the early periods, and later in the period at home when they were sick, there was some transmission, and later, as they became sicker, there was even more transmission. But it was still only about 25% of the contacts were infected. So, I don't know how we're going to devise an information strategy which will impact the public that believes if you go to Dallas and you come back, you should be quarantined because they had a case there. But we need to do that, and we need to look for a scientific basis for many of the things that we're using. Thanks.